send one to an old one. Sent a message to the April chat. I'm not seeing the May chat. Oh, I got it. I got it. I can't really see who is who though. Did that come through?
Yes.
Awesome. I'm gonna close this last one. I'm gonna do one where I said good morning. Good morning, everyone. This is Chair David Sanchez, and we are preparing to start this meeting. People are rolling in, so we're gonna give it a couple minutes to make sure we have everyone. As you come in, the state team will be making sure that you have access to your microphone and your camera. If you're a committee member, we ask that you have your camera on so that we can just maintain that we have everybody that's a part of the committee is present and available. Again, good morning, everyone. We're just taking a couple of minutes to make sure that everyone that is a part of the committee is able to get in and that the attendees, folks that are outside of the committee, are able to get into the meeting. As you enter, the state team will be working on giving you the ability to access your camera and your microphone. And we just ask that you bear with us as we start the meeting and get ready to set up. And Joan, just that your microphone is unmuted. All right. Looks like we're pretty close to getting ready to be kicking off this meeting. I'm gonna give it about another 30 seconds. And just ask that the committee members confirm that they're able to unlock their microphones and cameras. I can see almost all of you. Yeah, awesome, awesome. All right. Well, to keep on time with our day and our agenda, I am going to call this meeting to order. And we are going to start working on our agenda. This is the May 14th, 2024 Advisory Committee for Resilient Nevada. We're starting here at 10:04 a.m. And at this time, I'm going to ask our state staff to start us off with a roll call of members.
Jessica Barlow. Brittany Collins Jefferson. Lenitra Grady. Ryan Gustafson. Dr. Kamyar.
Present.
Carissa Loper. Carissa indicated that she was in another meeting and would enter this meeting when the other one's finished. Catherine Loudon.
Good morning. I'm here.
Elise Monroy Marsala.
I'm here. Good morning.
Darcy Patterson.
Present.
Jamie Ross. Colleen Sala. David Sanchez. Ariana Saunders. Cornelius Sheehan.
Present. Good morning.
Malika Toston.
Present.
Dr. Wagner.
Present.
Winnie Winbush. Winnie shows up as having logged in.
Do we have, is she able to unmute herself? Do you know if it's locked on our end?
No, she's listed as a presenter, so she has control of her mic.
And this is Ryan Gustafson. I just showed up late. I'm sorry, I was on the wrong link.
Okay. No,
Thank you,
that
Ryan.
gives you quorum. That gives you quorum.
Okay. And I would ask that the state team continue to observe and note if we get any other committee members entering the meeting a little bit late. I know that today, in the day of virtual meetings, we can have some pretty complicated technical difficulties, so thank you for bearing with us. At this time, it looks like we're good to go forward now that we have quorum. Quinny Winbush, if you do get the opportunity to unmute yourself and check in with us, please let us know that you're present if you're here. All right, I'll now move the meeting forward to agenda item number 2, which is public comment number 1. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment telephonically, please dial 75321-6111, and when prompted to provide the meeting ID, enter 500-416-849#. Please note that if you're joining by phone, press 6 to mute and unmute yourself, and press 5 to raise your hand. In consideration with others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on a matter discussed under this item until the matter is included on an agenda as an item on which action may be taken. Do we have anybody interested or available for public comment number 1? See a hand up from a phone number that I cannot fully make it out. It looks like the last 2 digits are 56. Attendee with the phone number ending, yeah, there you go. Can you unmute yourself? I just saw your hand go down. And it is, it's either star 6
This is Jamie Ross. Can you hear me?
We have you, Jamie.
Hi, I sit on the ACRN and I just wanted to let you all know I'm here. I'll be joining via computer shortly, but I'm on my phone as we speak. That's all. Thank you.
Awesome. Thank you for letting us know, Jamie. And Quinny, did I see you unmute yourself?
Let me see.
I got you. I can hear you.
Okay, all right.
Thank you.
You're welcome. Thank you.
Do we have anybody to continue moving on the public comment number 1? Do we have any attendees who are interested in providing public comment at this time? Joan, do you see anything that I'm missing, or are we good on public comment number one?
I see no raised hands.
All right, I am going to move us forward in the agenda now. We're moving on to agenda item number 3, and this is for possible action. It's a review and approval of the minutes from our April 9th, seems like April 9th, 2024 ACRN meeting. Committee members, you received a copy of the minutes from our last meeting, and our meeting minutes are posted on our website through the state. Do we have any committee members with any comments or questions about our last meeting's minutes? All right. Double check the hand raising. I don't see anyone unmuting themselves or raising their hand. Can I get a motion from a committee member to approve the minutes or deny the minutes? I went through them. They look good to me.
This is Elise. I'll make a motion to approve the minutes.
Thank you, Elise. Do we have a second?
I second it.
There we go. Thank you. All right. All in favor of approving the minutes from our last meeting in April, please unmute yourself and give us an aye.
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 Aye. Aye.
Any nays for approving the minutes from our last meeting? Anything off about the minutes that you saw? All right. Do we have any abstentions from voting to approve the minutes from our last meeting? All right. I got a handful of ayes. I'm going to accept that with no nays and no abstentions, and we will approve the minutes from our last meeting as finalized and ready to go. Okay, moving on to agenda item number 4, possible action to review, approve, and prioritize the SURG group funding recommendations. To kind of adopt them as our own recommendations that we will include in our report. We have a report due every 2 years to the director's office, and as part of our recommendations, we talked about briefly and looked over them pretty thoroughly. So at this time, I'm going to ask if we can get the SURG recommendations pulled up onto our screens and shared so that we can all see where we're at. Again, I'd ask that the committee members remember that our job here today is to lock down the priorities of recommendations that we're going to push forward into our report that go to the director's office, and then will be taken under consideration as far as funding directed by this committee. It's going to be pretty straightforward. You guys have all seen what the goals are, and then we have been shown which actionable items have been currently funded, are in the process of being funded, or earmarked for being funded. We've seen which ones are not being funded, and from there, we're going to gather a list of recommendations that are priority to each one of the committee members. Talk about it, add it to our list of things that we would like to see funded over the next couple of years. But we're going to start with the SURG recommendations to see if any committee members felt that any of their recommendations were important to tag along with our recommendations. Vanessa, can you share the SURG recommendation slides, please? And I will say that going over them again this morning, I found that there were 1, 2, 3, 4, 5 recommendations that look like they overlapped or aligned with some priorities for me as a committee member. Not maybe that one, but I was looking at the one from yeah, if you can get to, so this is the list of goals and recommendation or actionable items that the state put together for us, which I believe we're going to go over on the next agenda item. The slide that I'm looking for right now are the SURG recommendations from their 2023 annual report. Yep, there we go. Perfect. All right. Can you start us off at number? I don't know if they're listed on this one. Let me see if they match up to what I have. So yes, as we as a committee received these recommendations in an email with a little poll attached to it to kind of reorganize or reprioritize which one of the SURG recommendations, or I guess top 10, that we would like to see funded. Can you hit me? Can you go? No, I guess we'll leave it there. Mine is in a little bit of a different. Let me see yours. Yeah, no, I have mine numbered. Are yours numbered? Go down a page for me, will you please? Oh. Okay. There we go. Okay. These are the recommendations without being prioritized or numbered. So I guess let's just go back to the last page or the first page you were on last. There you go. Which we have support harm reduction through, and then it says make a recommendation. On my screen, I have this one attached to goal 3, which I'm not sure if you guys have your own information about the different goals that we have in the possible action items attached to them. But on goal 3, it specifically targets or works towards reducing the harm related to opioid use. I did list this one as one of the ones that I would like to see pushed forward.
Chair, this is
And-
sorry. Can I ask a question? Because I may have missed this. You know, when the ACRN was developing recommendations, we went through this whole scoring rubric, right, to sort of develop or prioritize score. Did the SURG recommendations go through a similar process?
Not exactly as thorough, but more internal, right? So they had these subcommittees, and then these subcommittees brought back their recommendations or areas that they saw that needed support. And rather than put them through an outside agency that would give them scoring criteria based on similar to the way that SEI did it for us, they did it more internal, to where they talked about each one of the recommendations that was brought forward by these subcommittees, and then kind of ordered them according to the committee themselves. So no, there was not a specific scoring criteria, but sort of internally, is my understanding.
Yeah, so I guess one of the issues I'm having is trying to consolidate SURG recommendations versus ACRN recommendations, because when I'm reading through this stuff, it has this sense that one, ACRN recommendations were held to a certain standard, which is we have to focus on our legislative priorities, right? And it's possible that the SURG recommendations hit on those same things, but I think that there are differences in the way they are recommended, and then we would potentially prioritize. And I think it would, at least for me, it would be helpful to see the same mapping for the surge recommendations as we've done for ACRN. Because if I'm going to recommend like a surge recommendation, and let's say just by happenstance, it doesn't even qualify because it's not hitting on, makes it tough.
Yeah, no, I totally see what you're saying, and I appreciate the perspective of how do we ensure that it aligns with the expectation of the statute or the guiding documents that got these two committees together. But at the same time, the SURG and the ACRN kind of go hand in hand with this subject matter expert group of folks who, and the SURG kind of, I don't know how to say it exactly because Don's not here. Joan might know the language that I'm looking for, but what I'm looking for is the SURG is, I want to say policy level, or how do you say it? Not organizational, institutional level. So I hear what you're saying about not going through the same matrix to determine how they qualify towards what it is we're supposed to be doing. But I have confidence that the folks that work on the surge took that into account as they pushed these recommendations forward. That when we finished our initial recommendations, we had 100 and something listed out, and we submitted this gigantic list of recommendations. The surge had to follow the same type of path to get them done. And I have Terry here who can help explain what I'm trying to say. Sorry about all that. Terry?
Hi, Chair, if I may.
Please.
Hi, this is Terry Kearns from the Attorney General's office. And just to hopefully try to address the question, is the surge did go through our legislation, and we had items A through Q that we're supposed to address as laid out in AB 374. And what we did was took those items A through Q and looked at each of them and decided which subcommittee would best address them. The three subcommittees being prevention, treatment and recovery, and response. So, and then there were some that were cross-cutting that went across one or two or more of the subcommittees. So each of the committees was then to make their recommendations based on the legislation and what was applied to that subcommittee. So from there, we had either subject matter experts come in and address it. For example, one of them was the topic of putting more prevention dollars. And so we had DHHS come in and talk about the dollars that are currently going toward prevention and fund mapping and those sorts of things. So then they looked at that specific amount of money, but we did parse it out based on what we were to do under the legislation. And the subcommittees then came up with their recommendations. Those recommendations then went to the larger surge. And at the surge level, they were ranked as you saw them in the presentation I provided. So I hope that addresses your question. I don't know if it gets into it. It's a little bit of apples and oranges because the surge addresses more than just opiates. We are to look at all substance use. So we had, topics on vaping and other items that may, or, tobacco that may not have been addressed by the ACRN.
Chair, this is Elise.
Thank you, Terry. Go ahead,
So
Elise.
we were provided a survey with these recommendations on March 12th to score. I think we had to go through it twice because there weren't enough respondents the first time, and then we did it a second time. So the ACRN has scored the surge recommendations through a survey that was sent out for the second time on March 12th Dr. Kamiar, is that what you're asking about our process for scoring the SURG recommendations?
Thanks, Luis.
Yeah, Farzad here. So, I mean, effectively, Elise, yes, if those are the ones that we are being asked to prioritize, like let's say that the SURG is saying, here's the ones that we want. Now, ACRN, you guys pick through this list based off of your criteria, what you want to recommend as priority. I feel that we would have to go through the same scoring rubric as this ACRN recommendations. Else, we're using different criteria for two things, for two sets of recommendations. And I understand that we were being asked to rank them. I think when I originally ranked them, it was just a rank, but it wasn't a formalized priority that effectively Mercer had done for ours, which I hope we'll get to at some point because I brought this question up a few times. I basically don't agree with some of the scoring on some of the recommendations. Yeah, don't we feel like that has to be done at a minimum? Versus sort of my opinion. I mean, my opinion maybe has some oomph or validity to it or whatever, right? Some impact. But fundamentally, I think to bring it to the table would need to be well, here's what Mercer said, or sorry, let's just say, here's what that scoring rubric is tied to these. Now, what do you all think? Because then as a group, I mean, we basically, I'm guessing, have the authority because of the existence of this group to say, even though this priority is showing as a 0, this is priority number 7,000, we can as a group say, too bad, we want it as number 1, right?
Yeah, absolutely, Dr. Kamiar. And so with that, no, I get what you're saying. Why wasn't it, or why weren't they, if they were going to be considered by us to be put forward to the state as a recommendation, put through an SEI type process to get a score to it, right? With that, I'm kind of battling the same thing that you're bringing up, though. If it was a 0 or 7,000, and we still, as a committee, thought that it was important, do have the wherewithal to push it through, regardless of what the score was, and that's kind of what we've seen happen as we received our, gigantic list of recommendations pushed through the scoring matrix, is that whether they were high or low, if they were important and we saw an opportunity for an actionable item that would remediate the harm from the opioid epidemic, they got pushed through as part of our recommendations. So I hear you on 2 points. It seems like these SURG recommendations ought to have gone through a similar type of scoring matrix, but that they did or didn't, I think the committee has the power to take them into consideration and put them through as recommendations. Is that right or wrong? I think we need the state's input on if that's in our purview or not. Do we have, I saw Dawn's hand up for a second. Is she here or not here? And if she's not, can I get a Joan or Vanessa to help clarify this issue?
Hi, Chair. This is Dawn.
Hey, Dawn.
Hi. Okay, so a couple of things. So we took all of the SURG recommendations because they did go through this very lengthy process. It was different than the ACRN originally had as far as our process and creating the recommendations and scoring them, but they also had the same ability to have the Mercer tool because we had Mercer do a Zoom recording of how to score the recommendations. So they did have that tool available to them as well while they were doing their recommendations. I mean, Terry knows more of the nitty-gritty of exactly how they came to be with the way they prioritized everything within their subgroups. But all we did was take the 10 that related to the fund, the state portion of this fund, and then we had you guys rank them. And then in the spreadsheet that Vanessa is sharing right now, or in the PowerPoint Vanessa is sharing right now, those are ranked the way you guys took the survey. So they are, just because they're not numbered 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, they are ranked. So this is how they came out within the survey that you guys took. So your number 1 was, you know, ultimately this was the number 1. And then number 2, number 3. If and I guess the question is like, do you want to see this move forward within your report? We can always go back and push them through the Likert scaling and the you know, the scoring rubric that Mercer did, and we can share with you the priority scoring of where it came out. But ultimately, you're saying, hey, prevention was our number 1, and that's where we want to focus a lot of the dollars. So I don't know if I'm answering your question correctly, but we can definitely put it through the prioritization rating scale. I just don't know if it'll actually change your thought, because the priority and the scores never changed your guys' thoughts before. So it's up to you though.
And so I guess the final thing that I would ask for clarification on, Dawn, before you have to go is, it does it or does it not have to go through that for us to push it forward? It sounds like it does not. It does not have to go through the SEI scoring matrix to be included.
Yeah. This is Dawn for the record. The SURG recommendations do not need to go through the scoring matrix because they're already put into a report. It's just a matter if the ACRN would like to adopt any of these to move forward into your report. And if not, that's fine too. It's just, you know, they did a lot of work, and if anything in here does stand out, then we want to make sure we're capturing it as well.
Awesome. Dr. Kearns, and then Dr. Camera, I want to check in with you to make sure that we're on the same page and that all sits right.
Chair, if I may.
Please.
The one thing that I would add is that each of the subcommittees did go through their recommendations. They worked on them by addressing justification and background, which included research and evidence-based practices. What was the impact, capacity, and feasibility of implementation, the urgency, and how the recommendations advanced racial and health equity. So there was a Likert scale that was used for those that each of the subcommittees looked at when they came up with their recommendations. So that was done at the subcommittee level, not at the SURG level.
Awesome. Thank you, Terry. Dr. Camera, does that kind of clarify things for you, or does that help at all?
Yeah, Farzad here. It does. Thank you, Dawn and Terry. So it sounds like this is only the sprinkling of SURG recommendations that would be considered for ACRN, since they do align. Fantastic. So I'm not worried about these not being applicable. It would be helpful just to see the same scoring rubric, because then we can sort of do an apples to apples comparison on what the impact is, the urgency is. Gosh, what was the other? Impact,
capacity, and
feasibility, and then legislative target, right? Those were the 4 scores that were assigned to them. And it sounds like they were already done. So just basically adding that so we could use that for reference would be helpful, at least for me.
Thank you, Dr. Camera. And State Staff and Dr. Kearns for helping us clarify and kind of get a better understanding of that. Through all that's been said about the process of getting these SURG recommendations to us, my general question for the committee is, are we at a place where we are interested in adopting any of these recommendations from the SURG? If we are, we can go through them now, talk about them, have people, you know, advocate for them to be added to our recommendations list, and then move forward. If we do not feel comfortable adding these recommendations to our recommendations from the SURG, we can hold off and move forward on what we do see as a need. Catherine Loudon?
Thank you. I would like to ask the group to consider this SURG recommendation to increase the prevention funding from 12 to $24 million. I believe that SAPTA and the SURG engaged in true due diligence when they brought this forward through the SURG. I am familiar with their process and the stakeholders and individuals who came together to make that recommendation. I was in a meeting yesterday with the DEA and looking over things from HIDA, high intensity drug trafficking, and they indicated that 7 out of 10 of the unregulated pills have enough fentanyl to produce a deadly dose. And we in the schools are seeing a lot of things among our families and young people, and having $12 million for the state of Nevada, just speaking from Washoe County School District, which has a geographical area the size of the state of Connecticut, and some 62,000 students and families and 8,000 employees. And I know that doesn't count our rurals and our Southern Nevada. $12 million is not very much money from the Substance Abuse Prevention and Treatment Agency. And I think if we're going to have a lasting impact from this fund, implementing prevention dollars and thwarting individuals to prevent, delay, and abstain or suspend substance misuse and abuse is very important.
Awesome. Thank you, Catherine. And committee, that's exactly what I'm looking for. As subject matter experts, where it is that you find, whether it's SURG recommendations or the recommendations that the ACRN has already listed, prioritized, and included in recommendations that we have not seen funded or that are earmarked for funding, I'd like to hear from you, to hear what it is your concern is, where it is that you can see a benefit from the recommendation, and how it is we can list it as a priority of the ACRN for the state to consider and push forward. Now, they may not do 12 to 24 million, but the point and purpose is there, right? When we make a recommendation, we show the emphasis of the need, how it'll affect outcomes and support the community, and then we've done our job. We can't control what it's going to look like on the back end, but we can control bringing it and highlighting it up as a need with a potential for positive outcome to remediate the harms from the opioid epidemic. So let's continue this type of conversation moving forward. And I'd like to stay out of the weeds with clarifications and going over the processes, but let's get to the part where we say, we've heard Catherine Loudon say that number 2, or I don't know if you have them listed, or on the page they're definitely not listed, but I see the recommendations listed on how we got them ranked based off of the 8 participants that answered at first. And this is the number 2 one. Recommend the Department of Health and Human Services double the amount of investment in SAPTA primary prevention programming. And as of that, I'm moving it over to the list of what it is we would like to see move forward. And if there are others, now is the time to speak on them. Elise and then Jamie.
Thanks, Chair. So I know you don't want to talk about the process, but I think the process is important because we took a survey to rank these and then we never got to see the outcome of the survey. So I would like to see the outcome of the survey. I actually ranked this particular, the prevention funding, lower on my list because we know that this funding is intended to remediate the harms. So I think the analogy that was given was to save people from getting on a bus, but we know there's people on a bus already. We know that the state could use additional funding for treatment. We know the state could use additional funding for harm reduction, specifically since harm reduction specifically, there are barriers to how we can use the federal funding. So I would actually prefer, before we take any motion on approving anything, I want to see the outcome of the survey that we did. I think there was initially just a handful of folks that did it, so it was resent, and then we never got to see the outcome of the survey. So before we take an action on approving recommendations, I think that we as committee members should be able to get to see what the outcome of the survey was.
Thank you, Elise. Jamie?
Thank you. I wanted to second what Catherine spoke on. I wholeheartedly agree. And also, I think that one of the things that I'm hopeful that I didn't see really come out of the surge was more funding for harm reduction, specifically, kind of in the same vein that we spoke of with really measurable outcomes for prevention. I think harm reduction is something that we should look at, looking at the same sort of recommendations we did with prevention with harm reduction as well. So I wanted to echo what Catherine had said and hope that we can make a recommendation, obviously not to the surge, but within our own to mimic what was requested in recommendation 1 that we're looking at on our screen right now for harm reduction as well.
Okay, thank you, Jamie. So let's go over Elise's concern of not getting the results of the second push for our committee's ranked recommendation or ranking of the surge recommendations. Does anyone else feel like not comfortable, or that because they didn't see the results of the second survey that we should not include these as we move forward? And I just got to remind you guys, our report to the director's office is due in June. So when we're done with this meeting, for the next couple of days and then a couple of days next week, I'll be working on getting that report done based off of what we take out of here.
But
So
why
if we're
would we
saying-
do a survey? Chair, I'm so sorry. Why would we do a survey? Like, take the time to do that if it's not going to be incorporated into the work.
But that's what I'm trying to get to right now, Elise, is that if you are saying that we shouldn't move forward with any of the surge recommendations because we sent it out, only got a little bit of people to participate, sent it out again, and then weren't shown what the second results were, that we should just not include them, then we're not getting any of it done. So
Why can't we see the results now?
I don't have them. I mean, I guess
Chair, this
it's
this
go ahead.
is Dawn for the record. Elise, I apologize. So it looks like some of these with the second survey, some of them are out of order, but during the first survey, we got 11 responses, and during the second survey, we got 13. I'm happy to share those on my screen right now if you'd like to see them.
So I do think that's what should drive the conversation. And I'm so sorry for coming off of mute, Chair. I will stop being a brat. I appreciate what we're trying to get to today 100%. I think that we have to use the information as it's been like collated by us through the survey to drive that. We shouldn't have done the survey if we weren't going to use the outcomes of the survey to drive what we were doing. Not only is that not fair to us who did the work, it's not transparent to the public. So that's why I'm like kind of being a butthead and a brat about this. So thank you for pulling this up, Dawn. I appreciate it. And I will go off mute, and I will not come off mute again until I'm called on.
No problem. And I apologize. I thought I had changed them to correlate with the 1 through 10. And so I do apologize for the confusion in the presentation. And so as you can see, number 1 from the 13 responses was the harm reduction, make recommendations to DHHS to utilize opioid settlement dollars to designate a baseline level. So Vanessa, can you move these so that they are in line, and then we can reshare the presentation, please. So support harm reduction is the number 1. And then evaluate current availability, or at least put a 1, 2, 3 next to the recommendation. I think that will be more helpful. Evaluate current availability and readiness to provide comprehensive behavioral health services to include but not limited to screening, assessment, treatment, and recovery services. That's number 2. This is the 1115. This one is already actually being done because we do have the 90-day pre-release waiver that we are doing the match for with Medicaid. Number 3 is the prevention dollar increase. Number 4 is leveraging existing programs and funding to develop outreach response providers and or personnel that can respond to any specific overdose or to those who are provided treatment of an overdose in a hospital emergency room, etc. Number 5 is implement a specialized child welfare service delivery model. Number 6 is harm reduction for shipping supplies. Seven, establish priority funding areas to ensure entry into treatment and recovery, ensure BIPOC, Latinx, Indigenous, people of color, LGBTQ. Number 7, disparities. Number 8, engage individuals with living and lived experience in programming design considerations and enhance peer support. Number 9, recommend that a compliance study be completed on NRS 259. And then number 10 is recommend Nishi complete a feasibility study for wastewater. Vanessa, were you able to get all those?
Yes, everything's fixed.
Okay. Can you please reshare?
Absolutely.
Thank you, guys. I really appreciate that.
Yeah, no problem. Apologies for that being not in order.
Thank you all for getting that done. Dr. Kamyar?
Farzad here. Don, you had mentioned that this was sort of a filter of SURG recommendations that might be ACRN specific. But I was just looking at like various documents to make sure that this is in line. But, you know, a huge part of ACRN is basically funding programs to treat the whole people on the bus thing. And I don't think really any one of these is actually talking about treatment. If harm reduction's in there and harm reduction is part of treatment, yes. But we're talking specifically treatment, MOUD, right? MOUD. I just want everyone to know that in the world of opioids, no single intervention is more effective and life-saving than actually treating the opioid use disorder, bar none. I mean, the evidence shows overwhelmingly this to be our priority or should be our priority. So if this is the pass-through of SURG recommendations, am I assuming based on that SURG didn't make any recommendations to evaluate treatment, expand treatment, implement evidence-based strategies for treatment? Because I know that's part of our task, right? It's definitely on our statewide projects priority list, right?
This is Dawn. When we went through the SURG recommendations, they had initially put funding sources in all of their recommendations, potential funding sources. So we only pulled the ones where they specifically mentioned this could potentially come from opioid funds or the FRN. And we did not pull all of them. We just pulled the ones that they mentioned us.
Okay, this is Farzad. Don, I mean, what do you think about that? Because it's sort of like eliminating programs right? I don't know right now how to feel about that. That we're sort of weighing in on things that don't have funding otherwise.
Well,
because is that part of our task as well, is to identify, like, let's say we prioritize between SURG and ACRN 1,000 different things, but 900 of them have funding in other areas. Would we only then, as an ACRN, consider the 100 that are left because they don't have other funds, and so we would then only prioritize those? and give ACRN funds to those?
This is Dawn for the record. Well, if you think about the opioid recoveries and litigation funds, our goal really is to fill the gaps in order to abate the opioid epidemic. So we are looking to fill recommendations for projects that are not at capacity. So I think both, Dr. Farzad. I know Terry wanted to speak to this question, but you know, this is one-shot funding, and the goal is to really change a generation. The goal is to push a lot of dollars towards the prevention in order to change a generation, right? And hopefully alleviate some of that treatment in the future. I get individuals on the bus currently, and we do need to do harm reduction. We do need to do the treatment as well, kind of all as a whole continuum. But it's just such a small amount of the pie. I don't know how to do it all.
Farzad here again. Yeah, I guess. All right, I'm just sort of looking at what we've been tasked to prioritize, and I'll just read the 14 different. So number 1, expanding access to evidence-based prevention of substance use disorders, basically treatment, right? Early intervention for persons at risk of substance use disorders, treatment for substance use disorders, and for persons in recovery. And then programs to reduce the incidence and severity of neonatal abstinence syndrome. That's treatment, basically. So far it's been on the bus. Prevention of adverse childhood experiences and early intervention for children. So the early intervention, absolutely, but it's for those that have already undergone adverse childhood experiences and the families. So this one is actually treatment, because if I treat someone who has a substance use disorder, then we know that generationally is when those effects will be, especially when it comes to ACEs, right? So that's still treatment. Services to reduce the harm caused by substance use. That's harm reduction, which is still treatment. Unfortunately, still not really prevention. Prevention and treatment of infectious diseases in persons with substance use disorders. So like in our program where we test for hepatitis and syphilis and all the STIs and treatment, right? So that's still treatment. Services for children and persons in behavioral health crisis and families of such. That's treatment. It's not prevention. Housing for persons who are in recovery. Treatment. Campaigns to educate and increase awareness of the public concerning substance use and substance use disorders. Let's throw that one as prevention. Criminal justice, that's treatment. Workforce for providers of services, that's treatment. Collection of analysis of data, treatment. Capital project, or let's call that prevention. Capital projects relating to substance use and substance use disorders. Implementing the hotline for persons who are considering suicide or otherwise mental health crisis or crisis. It's really tough to look. I am by no means, you all know me, I am by no means saying that prevention is not absolutely critical, right? Critical. It's sort of, there's a mismatch between what we're saying we're going to be funding projects and then kind of like what is being laid out as a priority. And then additionally, it's hard for me to sort of parse out ACRN recommendations, which I'm sort of viewing in my head as, oh my gosh, these should be the most important recommendations we are making for the entire state to use opioid litigation funds. But let's put the ones that I really think are super, super important to the side because they have funding. I'm not saying your job is by any means done easy, and I'm not saying that you've done anything wrong at all. Okay, so don't take it like that. But for me as an ACRN member to say, oh, well, there is funding for this, which I think is the utmost important, is going to save utmost lives. But then as an ACRN member, where I should almost be blinded to what are the funding sources? Because I thought that was like the director's office that would figure out, oh my gosh, they made all these recommendations. Cool. We already have these 5 funded through SOR or SUPTERS or whatever. So then we can fund this. And then we'll explain to the ACRN, hey, we didn't fund improved access to actual treatment. And we focused on this year prevention strategies because those guys were already funded. Woohoo, fantastic. But we still know that your recommendations are a prioritized list, which includes those at the top. And so in the future, if funding were to cease 15 years down the line, then, hey, we have ACRN funds available, right, to fund those, or given whatever the landscape is. So does that make sense, Dawn? I'm sort of like, I'm sort of taking a blinded approach as to what I'm prioritizing as recommendations.
Dawn, are you available to respond? Before we move to Dawn, let's see what Terry Kearns has to say. Sorry, Dr. Cameron, just 1 second.
Thank you, Chair, for the opportunity. I just wanted to highlight that there were some recommendations from the SURG that dealt with treatment 2, 9, and 16. Basically, it was, improving access to MAT to people within those special populations, the MAT in the jails and prisons, and then also trying to increase the workforce in the behavioral health setting. Those were the 3. And what I would add is we also, from the SURG, looked at the fund mapping. And for example, as I mentioned before, that prevention and increasing the funding, we looked at what was currently going to harm reduction, to treatment from the state, from grants, those sorts of things, and came up with our recommendations as well. Realizing too that on some of these, there are limitations on how the funding can be used within various grants and those sorts of things. But I just wanted to add that we did look at the fund mapping when we came up with our recommendations as well. I don't know if that helps or not, but.
Thanks, Terry. Until we get Dawn, Dr. Cameron, I just wanted to highlight that I see what you're saying about using the blind to what is existing perspective to better target the immediate need or the thing that would have the most impact. At the same time, the meetings that we've had previously to get to this point and really to develop our first report to the director's office were absent that. We specifically looked at what is currently being funded, and that's what kind of guided what would be a priority or how things would be ranked, graded, given that score through the criterion. So I see what you're saying, and I see how that is guiding the way that you're deciding what is important and what isn't important. But I think we've already established that we are going to look at what is currently being funded, and that will affect how the committee makes its recommendations. So I'm a little confused.
Farzad here. I guess I'm blanking on this. I remember the presentations that show, hey, here's like initiatives and here's goals. This is funded, this is not funded. Mm-hmm. But maybe I missed this. I don't remember for each priority that we had us having a mapping that says, oh, this is already funded, this is not funded.
Hi everyone, this is Vanessa. So I'm sharing right now just a short preview about the opioid fund mapping that we have mapped out. We did take some time to see what has been, what goals across the board, what treatment, what other grants are out there. So this is just a quick and small preview of some of the opioid fund mapping that we've been doing. And I absolutely understand, Dr. Kamyar, your point, and I think it's absolutely valid, and I truly appreciate it. And I think it's a discussion that we can continue, but I do want to make sure that this is at the forefront of everybody's mind, and I can absolutely share this with the group so that we're all aware of the mapping that we've done. And a lot of this covers treatment, it covers prevention efforts, it covers a lot of things, and just as Don had mentioned before, this specific funding from ACRN, we want to make sure that as we're writing up this next report and recommendations, this discussion is extremely important. And we want to move forward. If you guys have something different with recommending different recommendations as opposed to what SURG has recommended, that's okay. I think this is what today is all about. But I hope this helps clarify some things. Treatment is absolutely important, but we want to be able to fill in the gaps of services within our state. And yeah, so let me know if there's anything else that I can help answer, or if this helps clear up anything, and I can go through any other information that I have and share during the meeting as well.
Thank you, Vanessa. Elise?
Thank you. So I just want to point out what this shows. So what I'm seeing here. So it looks like there is about at least $100 million difference in what is spent on fee-for-service treatment and managed care treatment, kind of across the board. So I think, to Dr. Camiar's point, there's a significant gap in treatment. If we have a majority of Nevadans that are on Medicaid currently are on managed care Medicaid, and we're seeing, so what's that for fee-for-service OUD expenditures? $100 million difference in what is spent by the MCOs. And then for fee-for-service, oh my gosh, that's $5 million. That's huge. So I appreciate the wanting to make generational change. But this shows us that there's, at least this shows me, that there are significant treatment gaps.
And this is through the Medicaid expenditure, right? So does this committee have the power to adjust the way that fee-for-service opioid use and
We don't, but I think what this shows is that there's a disproportionate spend, right? So what does that disproportionate spend mean? If fee-for-service Medicaid is paying $100 million in opioid use disorder treatment, where the managed care organizations are paying $100 million less and they cover more lives, how is that translating, and are there service gaps? I would assume, if I can see that, if I see that the MCOs are spending $100 million less money in opioid treatment, I'm assuming that there are differences in treatment and there are coverage gaps. So how can the ACRN dollars be used to help support where there's treatment or coverage gaps?
and I guess my follow-up that I'm trying to walk the committee down is that's how I got to the currently not funded recommendations out of both the SURG and our recommendations from our goals and actionable items. That's how I got my list, right? Is that my hope is that the things that I put on my list will fall into those gaps that are currently money's not being spent on, or that the community could use support in terms of treatment, or I guess prevention or harm reduction. I mean, maybe I'm not understanding. Like I see the gap, and I guess I didn't see this before, but through what we've submitted and what has been presented to us, there are gaps that are obvious, and a need for funding and things that are not being funded. And that's what guided my decision to create the list that I have in front of me that says, these are the things that are important to me that have been listed as priorities of this committee. So I guess, Dr. Camiar?
Farzad here. Chair, thank you. Kinda. I'm gonna say kinda, because I think that, yeah, at that last meeting where we had the purples and the greens and the reds, that's sort of what you're talking about, right? Yeah. But now I'm sort of, wait, really? Because, okay, so like, for example, when I'm looking on the SURG recommendations, and of course there are multiple slides. So I'm looking at the online, it was like we're harm reduction, shipping supply, provide for shipping costs, or like harm reduction stuff. If it was not, and I could be wrong about this, but I thought that there was like, oh, whoever was funding the fentanyl test strips and the naloxone, right? Unless, so like in my head, I'm like, oh, that's already being funded, but then it's a recommendation on here, supposedly because it's not being funded, right? Wasn't that your understanding that this is, we're being presented with stuff that are not being funded, but those are being funded?
I am with you on that. And so my immediate assumption is two things. One, super important to me, and two, if it's a gap, and here's a gray area for me as I'm making my decisions, is it looks like this is already being funded. But if I list it as part of something that's important to me, is that like okay for the committee to push forward something that is already being funded, but
Well,
I would
yeah,
like to see
and
funded more?
that's sort of what I was bringing up, right? Is that I would love to be blinded to what's being funded because the folks at the director's office are way more versed in what's being funded and how much and for how long. I guess now that we're being tasked, or my understanding is that we're being tasked with trying to figure out what's funded and not, it's almost like I need more scores than the 4 that was provided. Now I need for each individual one, is it being funded? How much is being funded a year? And how long will the funding last? In order for me to then say, yes, look at this one. It's really important. It's maybe already being funded, but the funding's going to run out. So I want to list it as maybe a priority in 3 years, but not now. Versus this one is not being funded, and it goes deeper than these numbers because these numbers are showing overall expenditures, and it goes deeper than the green, red, purple sort of legend from last, right?
Yeah, no, totally. I totally see what you're saying. So what I guess, and in my process as I'm going through it, it's like that just made it more messy, to have to have the information about what is or isn't being funded, because it adds to the confusion of, does that mean I list it or do I not list it? It's still
Exactly.
super important.
Exactly. But I'm sort of hearing both sides now. So now I'm really not sure what to do.
Double not sure. Good discussion, and I appreciate it. Let's go, Catherine. Oh, you're on mute, Catherine.
Thank you. I know we need something comprehensive to benefit the state of Nevada, but as a group, can the ACRN say for Nevada to be more resilient, we must improve the Medicaid reimbursement rates for the state of Nevada for providers. We must increase the number of behavioral health providers. And can we also say that we have to have a comprehensive plan that includes prevention, intervention, and treatment? I mean, it makes sense that if Nevada is going to be more resilient, we need to have better Medicaid reimbursement rates. We need to have people who are using Medicaid have the ability to help choose their providers and feel empowered by that choice for themselves. And we need to have prevention. I'm wondering if, as a group, if the ACRN can make recommendations like that seem to be things that would help the overall health of Nevada over time.
So I get what you're saying, and I was looking at it earlier, talking about it, but one thing that would be broad recommendations is like the goal 6 from our previous work that we've done. Provide opioid prevention and treatment consistently across the criminal justice and public safety systems. So that's like a broad recommendation, and what all of our, what do they call it? They're like actionable items that are listed underneath there. If they're funded, then the state would, I think the state is going to do its due diligence to say it's funded, but only so much. Let's bump it up. And the reason why we're bumping up the support or to fund this more is because it was presented as a priority from this committee, from the SURG working group, so on and so forth. So I think there is room for like a broad level recommendation rather than specific recommendations from each one of the broad topics. I don't know. I know for me, it feels a little bit like, well, we're just giving it over and saying, good luck, state. But at the same time, it has been recognized as like, this is a priority for us. Please make sure that the actionable items listed underneath this goal are addressed. And then we will see through reports back from them that say, now we have this one that is funded. Now we have this one that is funded. Increased funding for this one. Still earmarked, still not funded. Time goes on. I think we're looking at a really complicated thing here, and that the target or hope of this committee is to do some serious, I don't know, support in ways that change people's lives, that support people's lives who have been, you know, really messed up through the opioid epidemic. And I think that it's, for me, keeping both like the bigger picture and coming up with the little or the more direct recommendations that could support these folks. It is a complicated process, and it is a complicated job that this committee is tasked with. But I think that getting something done at this point is a priority of mine. And so I'm hoping that people came prepared with some things that they are interested in seeing funded, and we can kind of get out of the weeds of going over process over and again. I think the process that has been set up for us and that we had a hand in guiding is not perfect and is messy and is confusing, but also it does give us a path to start walking down. And so far, what we have suggested or made as a recommendation as a committee has had results that have brought the thing to life, which is trying to help the folks who have gone through the opioid epidemic and been harmed in some type of way. Is it being done perfectly? Is it being done, you know, I don't want to say by the state, but as a community as a whole, well, I think we're seeing some positive outcomes, and I don't think we're seeing, I mean, time will tell. We'll look back and say, you know, this much money was put in the wrong place. But I think that as the committee has laid it out so far, treatment seems to be a priority, prevention seems to be a priority, and harm reduction seems to be a priority, which we have seen those things being funded in some type of way. It seems a little bit minimal to me, like, you know, that only specific areas, you know, there's the people that have presented that speak for their community, whether it's Washoe or, you know, Carson City, wherever it may be. And we're looking for, or hoping, I'm hoping to see a bigger picture of a statewide positive influence that this committee has had. But I think too, we're just doing one thing at a time, the next meeting. And currently where we're at is trying to get this recommendation, what's it called? It's the, hold on, I got the word. Report to the director's office, and then they can move forward. Is it a little confusing? Absolutely. Our meetings are filled with people giving us information, us taking that information and hopefully making little notes to highlight what it is important for us to see continue to be funded, to be newly funded, to be refunded. I hope that helps a little bit. I hope it wasn't just talking in circles. Dr. Kearns?
Thank you, Chair. I'm sorry to keep interjecting, but I just wanted to add that I know it's not going to help you in your conversations today, but I saw a tremendous presentation yesterday to kind of get to some of the comments Dr. Kamiar made by Medicaid. And they talked about amendments they're going to make to CMS for payment on treatment, such as, and also looking not only treatment, but quality and effective treatment, and giving incentives to those that are doing this. And also there was a slide that showed how many people are MCO versus fee for service. It was a very in-depth presentation. I suggest you go back and look at that. That may address some of your questions, but one question that came up is that we have a lot of people within the state that are leaving and going to other states. Is that a geographic issue? Is that an issue because we don't have enough treatment providers for youth, for example? And so they addressed that. There were a lot of things that were really, really addressed in that presentation that I thought were super helpful. And the talk about maybe not needing a facility, but maybe using both telehealth and mobile in some of the areas to address their needs. And once again, what really struck me is, you know, if providers are willing to go out to the rurals, for example, giving them a bump or an incentive because they're going to do that. But it was a phenomenal presentation. And I suggest if you get the opportunity to go back, it was to the Joint Interim Standing Committee on HHS given by Medicaid. Thank you.
Thank you, Dr. Kearns. And for me, Dr. Cameo, that's, or in committee, that's what guided me to make the list that I have, is that people present, people share what it is they're working on. And then from there, I'm looking at what is standing out that isn't being funded or that needs more funding. From there, so like the issue with the $100 million gap in fee for service and the other one, I don't, that doesn't, for me, it's concerning, it's an issue. I don't know how to solve it. But what I do know how to do is listen to the information that's been given to me, look at my community and my experience, and use that to guide the decision making of which recommendations are important to me to bring to discussion to this committee. That being said, some of the SURG recommendations didn't really stick with me, didn't really work for me, but some of them did. So though they weren't put through a process or enough information was given to help me make the perfect decision, it was enough to help me see an interest in promoting those as recommendations to the state. And I'll admit, I'm probably not the best at this or at even understanding how it's going to work out, but what I've seen is the committee has made recommendations, and those recommendations have had positive impact on our community. Did I know what each and every one of them meant or exactly where their priority was, or agree with their ranking through the SEI criterion? Not necessarily, but we as a committee push them forward, and there has been some yield or some results. Vanessa?
Hi, everyone. Thank you so much. I appreciate it. I just wanted to mention that I know it sounds like the SURG recommendations have a lot more work, or maybe before we want to move these forward in the report, we can just stick with the ACRN recommendations. I know that the report is due at the end of June or in June. So yeah, I think it'd be really great to just stick with the ACRN recommendations if you agree. And we can discuss that. I know that you are seeing gaps, and this is important discussions, but I think we can start recommending these things and making a list. What we were sharing previously was ranked on the survey results. So my suggestion is, let's do what ACRN is called to do. And if SURG is recommending some things right now that we're not necessarily in agreement with, or it's causing confusion, we can just focus on what you have all recommended with the 10 goals. I think that'd be incredible. So that's it. That's all I had to say.
Thank you, Vanessa. So right now we're on agenda item number 4 for possible action. Review, approve, prioritize the SURG recommendations for possible inclusion in the ACRN report. How does the committee feel about moving forward with any of those as a recommendation in our report? Or are we at a place where we cannot move forward with them because we don't have enough information or enough of their recommendations pushed through the process that we would normally go through? Elise?
So I'm comfortable including the ranking of the surge recommendations that these committee members did in our annual report. I think that is probably the most appropriate way to get there, right? To like approve them is to include the ranking. I also think it would be helpful, and I would just like respectfully request of staff to do their best to summarize the robustness of the conversation that we had today as part of the final report. I think that Dr. Kamiar hit on some really important, really important things about how complicated it is to fund this work. We can't, and I think that we're like cutting ourselves off at the knees if we just say, well, treatment is funded by health insurance and Medicaid, and that is a problem for somebody else, somewhere else, not for us. I just would request that if there's a way to say that like we acknowledge this was a challenge for us and these are the reasons why, I think that's important to include in the report if possible.
Yeah, well said. Thank you, Elise. I know it's going to be a heck of a task for the state staff to go through this and add this as minutes, but I think it's important to note that like the whole of the thing that we just went through, that we're talking about something very complicated, and that also it's a big task and undertaking, and that yes, it would feel weird to just say, oh, it's too big, so we're going to skip, but that we need some plan in the future to have, I don't know, a proper or a process that would help us navigate that part of it when it seems too big. That how can we, what is our part and how can we address it? Definitely. Okay. So that being said, looking for committee members to give us their thoughts on where we currently stand. And I think I'll narrow it down a little bit too. Right now we have those 10 recommendations from the SURG working group prioritized by our committee. The question to the committee is, are we interested in pushing those through and adding those to our report as something that we recommend? Or are we going to abstain from adding those because we're not completely all on the same level, or at least understanding of how they apply to what can be done in the future as recommended by the ACRN? Dr. Wagner.
Hi, Carla Wagner. I think I would be comfortable doing something like what Elise is recommending in the report, specifying that we reviewed these things. They were given to us by the SURG. We ranked them. This is our rankings, and this is as far as we got. I'm not hearing a lot of consensus here on how to move forward, but I think we can at least report accurately that we got that far. And maybe highlight some of the concerns around the process. But I'm not comfortable at this point kind of putting an endorsement on these as recommendations. It's my 2 cents.
Yeah, I really like that. That it is included in our report, but it included in our report as this is what we've done so far. This is where we left it off as the submission of this report. And then find out how we pick up after that. Malika?
Hi, I'd just like to go, Malika here for the record. I'd like to go on record saying that I agree with Dr. Wagner, Kamiar, and Elise. I would have liked to have, me personally, as a person in long-term recovery, I would have liked to have seen more funds towards of course, the hospitals and institutions, because this is where we see that they need a lot of help. And as Dr. Kamiar said, that is treatment. More dollars going toward actually treating the person, and of course, early intervention in mothers. So we have less kids born with withdrawal and addiction. Because that adds to the problem that we already have. I would also have liked to see some childcare, some job resources. Because some of these people they're using because they're not working and they have nobody to keep these kids, which is also a DFS problem, and adding to the opiate addiction. So no, at this time, I am not on board with submitting this SURG recommendation, but I am on board with submitting the ranking. Thank you.
Awesome. Great. That really feels like we got a little bit of somewhere and something done. Catherine. Oh, you're muted.
I wanted to add one more thing to this. I heard this committee, it didn't seem like anyone even fully understood the SURG or the voting members on the SURG or the doctors or prevention specialists or community providers that are our shoulder partners that contribute to the SURG and came up with these recommendations. So in the future, I would love to see, as a committee member, us get the whole who was on the SURG, who helped contribute to the SURG, what other professionals were involved in making the recommendations before we make a decision to not include the recommendations of colleagues that we all work with that were a part of the SURG to begin with. Because when I look through the SURG's minutes and I look at the members of the SURG, I see people that are certainly our behavioral health colleagues, and we may be disregarding their input and information without even understanding who they are and the processes that they went through to make those recommendations.
Thank you, Catherine. And I will say that I believe the state staff has done a pretty good job, because we have been given a couple of presentations from the SURG in terms of who they are, what they're working on, what they're composed of, and what they're doing. So I also feel that the way that I have gotten to where I've gotten as far as understanding what recommendations that I would like to see move forward is a direct result of what has been presented to us as kind of put together by the state staff. And I mean, I don't have a perfect understanding or even really good understanding of how the SURG processes work, but I do have a pretty good understanding of who they are and how and what it is their goals are, or like how it is that we're tied together. I mean, not perfect, but some sort of understanding. I'm going to go Jamie Ross, and then I'm going to go Dr. Camera. Oh.
Thank you, Chair. Jamie Ross for the record. I just wanted to say, if I'm being totally honest, I think we're way overcomplicating this. I think the goal is to make some recommendations, put some stuff on paper. The reality is most all of these recommendations are going to sit in someone's office on a shelf. And I think that this is now the third meeting that we've had to try and discuss this. And I would, again, I realize that I am in the minority and I'm totally fine with that. But I just wanted to go on record and say I am happy with both putting in that here is the ranking and also putting in the recommendations that we've spoken about today, where Catherine and I both affirmed that we would really like to prioritize prevention. Dr. Camiar really wanted to prioritize focusing on evidence-based treatment, and all of the other recommendations. I would absolutely be willing to say, yes, let's put both of those down on paper, get them in a report, and then have that report sit on a shelf somewhere.
Thank you, Jamie. And not to oversimplify it, but that's sort of where I'm at, is that we can say give $10 million to Carson City Health and Human Services, and the state can choose. That's our highest priority. That's the rank number 1 1,000 times over. And then the director's office can be like, no, we're not going to do that, and then move forward. So I'm not saying that we have no power in our recommendations, but I'm saying that our recommendations are just that. They're just like suggestions, recommendations that are going to go upwards, and they may or may not be followed up upon. So let's do our part, which is pretty straightforward. Give a list of recommendations that are meaningful to each one of us as individuals and that are agreed upon by the committee. Let's do that. The two that we've heard so far, with some, how you say, like importance brought forward by the committee members that have spoken, I love it. That's definitely something we should add in our our report as far as our recommendations. Dr. Kamiar, then Elise.
Yeah, Farzad here. To Jamie's comment, I'm actually trying to remove any personal bias I have from this. I'm basically simply looking at the priorities as outlined by our NRS, and the overwhelming majority of them talk about preventing overdoses, access to treatments. Absolutely, youth prevention is in there, but let's say if you put 14 different criteria that the ACRN designed to make it the purpose of our group, significant proportion of them talk about treatment specifically. So it's not my personal to say I'm only going to prioritize treatment and I'm not thinking about prevention. I'm
Dr. Cameron, can I hold you right there? I'm sorry to interrupt you. Quinny, can you mute yourself, please? There we go. Sorry, Dr. Cameron, it's really hard to hear you with the background noise.
Yeah. So I mean, effectively, I was just saying that I'm not trying to bring any sort of my only priority is treatment or my overwhelming priority is treatment. I'm really trying to stick to what has the NRS outlined as the programs that we have to fund. I mean, I read the list of the 14 specifically I was reading from the NRS, and they say that that ACRN has to fund these programs. These are the programs that we sort of need to include without limitation. And it just so happens to be that the overwhelming majority of those criteria that are outlined of the 14 have to do with treatment, right? And then the other question that I was going to ask is, I don't recall how we went from our 100 or so recommendations to then the list that is being outlined under these, like goal 4, for example, that we're being presented with, and we've had presentations on with the green, blue, and the purple. Chair, do you remember how did we go from the big shebang list to, okay, now here's the 5 under this subsection?
So I think the 100 and something that went forward were then broken down into I'm getting to the top of it right now, but I want to say okay, what did they meet the legislative criteria? If they did, then they were scored and included. And then also, where was the gap that they were filling? Treatment, data, prevention, harm reduction, secondary prevention, system needs. And then that was all smashed together after we submitted, and then like, I don't know how do you say it, like processed through where do they fall? Do they fall in data? Do they fall in prevention? Do they fall in harm reduction? Do they fall in direct treatment? And then that list was listed out again as scored in the criteria on with the high, with this number, and this is the gap that it fell under, and this is the target or the section that it fell into. So I think that's how we got to the 7. What are they called? They're called strategies, or like the area that they fell into. So like capacity, prevention, harm reduction. Again, yes, super complicated, right? Super not clear either.
So this is Farzad. And the reason I asked that is because I'm fairly confident, again, could be wrong, that there's a disparity between those lists, that there are items that dropped off and are not included now, like under goal 4.
For sure, because we would have 7 goals with 20 something recommendations in them, and we don't have that.
Yeah, so it does seem like a further distillation occurred.
Mm-hmm.
And I'm not sure how.
And I'm not sure how either, besides that the state staff whittled it down, reorganized it in a way that would not present so many duplicates or recommendations that were feasible, or because there were some recommendations that we had on our initial report that didn't really make sense, right? They were just included because we grouped them all up. We're out of time. Let's put them together. These were important by the committee members, so we're agreeing that everything that was important to people were going to be added. Some of them didn't really make sense, or maybe even fall into a category that we were supposed to be targeting. We're kind of in a similar situation today, it sounds like, to where we're at the point where we must submit recommendations, get them into a report, and hope that the state does something well with them when they get to the director's office. The thing that I'm hoping is that we've had enough information given to us. There are going to be gaps. There's going to be some confusion on the processes that took place to get us to where we're at, but that we can still use our subject matter expertise, our communication and work together that we've done so far to get some type of list together. And even then, I don't even know if and how we're going to prioritize it as we submit our report. But using what we've seen that is funded, not funded, needs to be funded, we come together right now today in the next hour and a half to get a list of recommendations that we can push forward. And I think we put that little caveat at the bottom, like we were talking about with the SURG recommendations. One of the SURG recommendations is super important, and now we can adopt it. Are we going to adopt them all? We're going to submit that list as prioritized by people who looked at it. And at the bottom, put this is where we got on this process, but this is where we're at with it. But also, I don't see anything wrong with saying that one of the priorities of this committee was one of the SURG recommendations, and we have now adopted it as our own. Super messy, not exactly clean, a lot of room for what is that called, where we're not seeing the full picture. But I think if we keep it simple, rather than overcomplicate it, like Jamie brought up, we can still do some good, and we have done some good. Even with all that being said, we're seeing impact in the communities. Is the impact that you've seen so far that has been presented as funded, is it meeting what you would like to see done? And I get the objective, is it just based off of me, or is it based off of the need and what has been presented to us? I think we can get somewhere. Dr. Cameron?
Yeah, just a couple of things, and I'll go back on mute. One, I'm guessing someone from the state is going to weigh in on this, how that distillation occurred. It's possible that within each category, they just took the highest 5 priorities, right, that ranked highest. Unfortunately, if that was the case, a little bit of concern, because again, I had sort of questions about the scoring to begin with that happened. And then I think it is important to address Jamie's concern, because I'm guessing she's probably not the only one that has some of this sentiment, which is let's generate a report that can sit in someone's office. Yeah, I would I would agree. The state folks are absolutely freaking amazing. But at the end of the day, it would be a shame if that's what happened. Thanks for bringing that up, Jamie.
And okay, I definitely hold that same sentiment, that it would be a shame, but also that it could be a likelihood. Again, we can overcomplicate it and concern ourselves all the way in a million different ways. But we made recommendations, and we have seen the fruit of those recommendations already. Let's continue that same path. We can hold all the possible what ifs, and this isn't going to work out, and we don't have it exactly down the way we want to. But even with that, we still did some good to the community. We're still guiding processes, or at least support and funding towards some programs that are super valuable to community members' lives, that are changing the way that they live, that are helping them remediate that harm from what the opioid epidemic affected them. It's happening, even with the messiness. I would advocate that we stick towards that type of sentiment. I'm going to call Lisa, and then I'm going to step away just 1 second. I'll be able to hear you, but you guys won't be able to hear me or see me.
Thank you, Chair. So I appreciate Jamie's sentiment that, that this is being overcomplicated, and I'll just be like super transparent with the group. The recommendation about the $12 million has my tail poofed. So I have a poofy tail, like a cat would, right? So my tail is poofed over that recommendation specifically. So I'm uncomfortable saying, just put it in a report. It's going to sit on someone's desk, because I'm so uncomfortable with the big picture of all of this and how disparate the funding recommendations are. So if we incorporate the $12 million recommendation into our funding, but don't then adjust the recommendation for harm reduction, we've now created a situation where we are saying, well, first of all, I believe that this funding, the opioid settlement dollars, are intended to mitigate the harms of overprescribing, of bad actors. I have yet for someone to tell me how primary prevention mitigates the harm of people who are addicted today. I just don't get that at all. And the recommendation from the SURG does not define what prevention is. In my mind, because of what I've seen the state fund, prevention means primary prevention. I wholeheartedly do not believe that primary prevention will mitigate the harms of bad actors and overprescribing. So I'm uncomfortable incorporating a $12 million recommendation into our total package of recommendations, where what currently sits is $140,000 a year for harm reduction. So those are people who have actively been harmed, actively, and are living with active harm from overprescribing, from inappropriate dispensing, all of those things. $140,000 a year. Over 3 years, still less than $500,000, but $12 million for primary prevention. And we've been presented today, we can see that there is a huge gap in funding for treatment. So that is why my tail is poofy about this recommendation specifically. I am uncomfortable saying $12 million for primary prevention, continue to underfund treatment, continue to underfund harms, and then when all those people die, they'll die. We won't have to put harm, we won't have to help them through harm reduction, we won't have to help them through treatment. But we've allocated less than $1 million in 3 fiscal years for harm reduction. So it's incredibly disparate. So that is why my tail is poofed and why I'm uncomfortable with that recommendation specifically.
Thank you, Elise. That's exactly what I'm looking for, is a conversation back and forth, and then tying it to, our directive, what our goal is, what our job is. It seems like you made a good point to say that the prevention may be all over taken care of. Not that prevention doesn't need support, not that prevention couldn't use or couldn't benefit from doubling the amount that is provided in funding, but that is not necessarily a direct response to mitigating the harm. That's what I'm looking for, this type of conversation. Thank you. Malika.
Okay, so once the report goes in the end of June, let's say we include everything that's, we've done and what we talked about today. How soon will we know that the recommendations are approved? What happens from June till then? In your past experience with allocating funds?
Yeah, I think so. So I think what happens is the director's office gets it, the director's office goes through it, the director's office pulls and picks and chooses what it is they want to do with those recommendations. They're like, oh, look at this one, it got brought up again. Oh, look at this one, it's a really important one to them. It's a high priority. Let's put out a NOFO for this type of service, or let's put out a notice of funding for something that responds to this recommendation. And then people apply for it, and then they put it into application, and then they have results, and then they report back to the state, which then reports back to the committee.
Okay, so there's no likelihood that they're going to choose 5 or 3. Like, we don't really know out of those 10 which ones are the most important to the AG's office or the state HHS.
Yeah, no, we don't know. We don't know going in. Ours is just a look at this entity. They have been tasked with getting this done. Now that they have it done, they've given it back to the state director's office, and now the state director's office will do what they will.
do
then
with
we
it
will
what
see
they
the
will?
results,
Okay.
and then we will see the results through some type of reporting that says has been funded, and this is what it looks like in action.
Okay.
Now,
So our
and I don't think
recommendations could go or not go. So regardless of whether we put them on this report now or sometime in the future, they ultimately may not all make it.
yes, and what I've seen from this meeting is it seems like a big call out again for the need to increase funding towards harm reduction and treatment, which we keep
Right.
getting back to this, like eventually, like maybe not meeting, 3 meetings in a row, but eventually after 4 meetings, 5 meetings, we'll hear the same sentiment.
After 4 meetings.
Being a lot of
All
why are we
right.
not paying attention to this? How do we pay attention to this more? And that's awesome. So now all we need to do is add verbiage to our report that says gigantic gap in treatment, gigantic gap in harm reduction. Please, fund these 2 things in this type of way.
All right. Well, I kind of
Can I say-
changed after listening to all that. I'm kind of changing my decision. If it's possible, put it on there and we'll see what happens.
That's where we got to in the very beginning, Malika. And something came out of it. Wasn't perfect, was real messy, and something came out of it positive. Thanks, Malika. Quinny?
Yeah, I don't know. I guess you can't see me raise my hand or something. Everything is messed up on my side. But anyway, 20 for the record. I just wanted to say before we get off, I just wanted to make one comment that I feel, I think that it's really sad to hear that we're just here on the ACRN board committee just to make suggestions or recommendations. For our recommendations or suggestions to sit on the shelf, when in fact that I thought that the recommendations and suggestions were to possibly save future lives. So I'm just saying this just to put it out there. That's it. I just wanted to make that comment today because I got a feeling that earlier, just by the statement Jamie was saying that, just directing at Jamie when you were saying that don't take it so serious because these things were going to be put on the shelf. So I was just wondering about that.
No, I appreciate that.
Sure, David. Sorry, this is Vanessa for the record. I absolutely understand the confusion and the frustration on that, but I do want to clarify that while we created the statewide plan, we took all of your recommendations and broke them out into different activities under strategies, under the objectives, and we tried to fit all the recommendations as ranked. Mercer did help us to do this as well. So I just want to make sure that that's clear because I know I want to make sure you are all aware that what you're doing is so extremely important. Your recommendations are incredibly important. We do take them into consideration and we do our best to translate that into the statewide plan. And I truly am proud about proud about the statewide plan and how we rank the goals. I think it's done such an incredible difference. We've funded some amazing organizations, and we have created incredible partnerships throughout the city based on the recommendations that you have all given during these meetings. So I know sometimes we can get into the weeds and it can feel like nothing's changing, that we're not pivoting, that we're not moving forward, but there is incredible work that is happening through these funds, and it's all in consideration with what you have all recommended through these meetings. We're only allowed to fund based on the statewide plan. And again, this is an opportunity. When you guys are giving this report, we are going to be rewriting the statewide plan. So if goals need to be shifted or whatever the case, whatever it is that you guys are recommending or want to see different, these are the meetings where we could discuss it. And I absolutely hear you all. The state is hearing you all in terms of the gaps in services and the new gaps that you guys are seeing and the things that are now concerning to you all. But I appreciate these conversations because we're all becoming aware of this and these are the things that can change, and you can shift your recommendations here in these meetings and we'll do our best. But Quinny, I absolutely understand and I appreciate your comment. It gave me an opportunity to also let you guys know that we did our best to translate everything into the statewide plan. I hope that helps.
Thank you for that. Yes, it does. Thank you.
Okay.
Appreciate it.
And these conversations got in the last statewide plan, correct, Vanessa? Like the back and forth that we had in the beginning as the ACRN, what we talked about, what we determined as, needs or our recommendations or the questions that came up, the conversations that we had, correct me if I'm wrong, that had a part in helping guide the previous statewide plan, right? Needs assessment.
Absolutely.
Needs assessment.
Absolutely. Yeah. So that's what I'm letting you guys know, that these conversations and your recommendations are helping us guide and write the statewide plan at the moment. And it has before and will continue to do so. We do care. You guys are all subject matter experts. And we need you guys to discuss these matters and recommend and shift and change and pivot. We do want to change and pivot a generation, absolutely. That should be a goal for all of us moving forward, but we understand that there's present things, just as Dr. Kamyar mentioned, there's present things that we need to be looking at as well. So yeah, I hope this conversation helps and I'm able to really ground us in this moment and make sure that we're able to focus on the importance of what you guys do and the recommendations. And we have the opportunity to shift and rank them all.
Awesome. Thank you, Vanessa. Jamie Ross and then Dr. Kamyar.
Thank you. Jamie Ross for the record. Thank you, Chair Sanchez. Just wanted to mention a couple of things. For most all of the funding that is, because the reality of the situation is most funding that is currently going to anything substance use is federal grant dollars. There is very little in the way of state general fund money that lives in this area. Almost all of it is state opioid response, block grant, overdose data action, those sorts of federal funding priorities. To speak to what Elise said about prevention, I wanted to mention that 80% of those grant dollars for the major grants, 80% of those dollars go to treatment. And if we're lucky, 20% of them go to prevention. So to state that there isn't, that obviously every single area of this is underfunded, period, end of statement. I am not saying, but I did want to correct that assumption that there is more money going to prevention than there is to treatment. About 80% of it does go to treatment. Obviously, hugely pro harm reduction. I would love to see a recommendation for both prevention funding as well as harm reduction. I think that both are incredibly important. And as far as what is prevention named, sitting in on the SURG prevention subcommittee, we are speaking on primary, secondary, and tertiary prevention, or indicated, as well as, I can't remember the other word, depending on what version, if we're looking at the CDC or the SAMHSA definitions, but when we speak of prevention, it does include harm reduction. So making sure that that is acknowledged, that as far as the SURG subcommittee is concerned, we are speaking absolutely of harm reduction when we speak of prevention, because it is, again, it's all a spectrum. And I wanted to apologize.
Jamie, the state doesn't consider harm reduction and prevention the same, which is the problem and why we need to be clear in what we're writing.
Which is why I'm suggesting we add a specific harm reduction section in the same way that we have the prevention, because we are dealing with really imperfect systems with a lot of people who may not have the subject matter expertise that the people in this group do. So let's go ahead and let's make it specific. But I agree with you. I think that there is maybe some confusion on what all of these things mean. And then I wanted to apologize to this group. This is going to sit on a shelf, has nothing to do with this meeting. This has to do with the I think I figured it out, 11 other of these committees that I have sat on over the years, and by no means is this an unimportant project. I think that it is an important project, and I know that it is valuable. It was a very inelegant way of reminding us that this is maybe not, we don't need to complicate it as much as we do. So I apologize to this entire group for what I said, and more specifically the way that I said it. That was never my intention to discount the importance of this group. So thank you.
For sure. Thank you, Jamie, and thank you, Elise, Queenie. Awesome. You know, I'll just sometimes it can feel that way, and you know, thankfully, we've seen the opposite. We've seen where our recommendations, this group's work has come into fruition in the communities and made a difference. We have much more work to do, and we are not the ultimate authority of how that's going to get done, but we still have a target ahead of us. Right now, I'm going to move us forward from this agenda item. I'm going to close it up with Dr. Kamiar. Well, I guess I need an agreement. I don't know if I do need an agreement, but for possible action, it says, does this committee want to make a motion to include the recommendations from the SURG with a little excerpt at the bottom that says, this is where we got on working on these recommendations. We wanted to make sure that we didn't get the time to completely acknowledge, and how did we say it earlier? Can someone help me wordsmith that out? But basically list them in our report, not as 100% in agreement, but that we worked on it and we're going to continue working on it. No? Anybody?
Well, I think that we had talked about including the ranking. So including the list of SURG recommendations as they were ranked by the committee. Yeah. Perfect.
Dr. Kamiar, do you want to give us your last thoughts before we move on to the next agenda item?
Yeah, as far as out here, a little bit about that, but that wasn't my main point about the ranking. I don't know. I'm not sure that maybe I even feel comfortable saying this was my ranking, because I was just throwing stuff on a survey sheet, right? Yeah, I think this is important. Yeah, I think this is important. Yeah, I think this is important. But what's the actual impact? I don't know. That data wasn't provided. And for me, that stuff matters. It matters to me. Like I had mentioned earlier, I am trying my utmost to reserve sort of any biases that I have in what is important versus not, and really taking an evidence-based approach, right, which would take into account Mercer's scoring system. So there's that. The point that I wanted to make was, before I had mentioned, I didn't realize that we were supposed to take into account funding sources and only recommend what's being funded versus not. And I'm taking a blinded. I was wondering, where did that come from? And Chair, you had mentioned, oh yeah, at some point we were tasked with trying to figure out what is funded and what's not in order to prioritize those. The reason being, I am going to quote the very first sentence of the statewide needs assessment. The Nevada Department of Health and Human Services Director's Office Fund for a Resilient Nevada unit is responsible to administer the funds for a Resilient Nevada and to supplement and not supplant existing funding focused on opioid use or opioid use disorder in Nevada. Specifically, it's one of the policies, which is the principles. It's one of the John Hopkins principles that we adopted, which is this will help ensure that dollars from any opioid-related settlements are additive to existing efforts. So now I am going to say I should in no way be considering what is funded and what is not funded. That's going against the first sentence of our statewide opioid needs assessment.
Thank you, Dr. Kamiar. Yeah, and you know what? I'm looking at I'm looking at the Advisory Committee for Resilient Nevada bylaws. There's something about Our part in creating the state plan will prioritize overdose prevention strategies, youth substance use prevention, and focus on health equity, so on and so forth. That being said, I think that we need to make a note of these issues and really get to work. So I don't know if you guys noticed or remembered, but during the because we don't have a report due 2 more years, and then we hear updates nonstop. We come to these meetings once a month, we hear an update. It's people presenting to us about what has changed. I think what we're highlighting here is the need for active participation of committee members to help clarify, review, and direct these processes, which get us to this final meeting report day. Does that sound accurate? Okay. After Dr. Kamyar's giant bomb about the not supplant but support these existing programs, how do we as a committee feel about moving forward from this agenda item to start making a list of recommendations and include the SURG recommendations with that little caveat of this is how we prioritize them, still more work to do? Any thoughts? Conversation? Hearing none, we have 2 options moving forward. We could hear a motion to include the SURG recommendations as prioritized or ranked by our committee, or we can move forward to the next agenda and leave them out. Committee's choice. Or we can talk about it and find out what it is we're going to do. Anybody have anything they want to say?
Farzad here, Chair. Would the whole sort of we're supposed to remove the funding as prioritizing criteria? Would that feed back into the SURG recommendations that were even presented to us? In that these are funded versus not funded and applicable to the ACRN? Isn't that what I thought that's what Dawn had said, right? That we got filtered the ones that were not funded but identified as being important. And
that sounds right. That sounds right.
And given the fact that I'm really not supposed to rank anything based on funding source, but more so what I feel important, would that mean that there are other SURG recommendations that I might prioritize above the list that we've been provided?
That is true.
So then I would wholeheartedly say I personally would not feel comfortable saying or including SURG recommendations because I don't know what the whole list is that I would want to prioritize.
Yeah, that checks out. My only problem with that is if we did that right now, moving forward to everything that we have been given, everything that we've considered, then the whole thing would be we have no report this year. If that's where the committee feels that we're at, then let's do that. But again, I like the sentiment passed forward by Jamie Ross of overcomplicating it can get us stuck in the weeds and in a place where this committee has little to no input on what the state does with the funds from the litigation. I forget the word for processes, and we really don't have any input on what that looks like. I would ask the committee that given this highlight that Dr. Kamyar has presented to us about the issue of knowing what is funded or what isn't funded and how that affects our considerations, that we move forward regardless, that we move forward with what it is that we see can help remediate the harms of the opioid epidemic, as we've done so far with possibly apparently the wrong perspective or lens as we moved through what we've got done so far. Elise?
So I actually would take Vanessa's recommendation to roll our existing recommendations forward there are a number of recommendations. So like if we're looking at the goals and the objectives, there are still many things that are not funded yet. A lot of things that are not funded yet. So I would be comfortable, and I could make a motion, but I would be comfortable recommending for this next report, rolling over the goals, objectives, and priorities as they are, considering there are so many things that are yet to be funded, and including in the report a summary of this conversation about the ranked recommendations and the concerns on either side. So like my example with like the inequities, Jamie's example about not getting a full picture of like how prevention dollars are spent and treatment dollars are spent. So the motion would be so the ACRN would, so I move the ACRN uses its existing goals and objectives for funding in the next 2 years and include in the annual report the ranking of the SURG recommendations and an analysis or conversation, documentation of the conversation about the challenge of ranking and incorporating the SURG recommendations.
That is like the best news I could have heard all day. Thank you so much. Let me just tell you this. My broad recommendations are the whole of goal 1 that we didn't already support with funding, the whole of goal 3, 5, 6, 7. And then after that, I simply listed the ones that fell into those categories or that were outside in our initial recommendations, copied and pasted them into my list. But what you just said covers all of that. What it does is it leaves the state, it hands over the package to the state that what we suggested and the way we have it lined out right now isn't perfect, isn't 100%, but it is what we have already lined out, and these things are still important to us. There are some huge gaps that this committee needs to get clarification on, or if they have a part in helping organize the process of how this is done so that we're all on the same page and there isn't this kind of gigantic what do you say, wordsmith bomb that falls into our lap that really kind of skews what we have done and what we're going to do forward. We work on that moving forward. So I guess I'll just close with thank you for the excellent recommendation, or not recommendation, motion. Do we have any seconds for that motion? Oh, go ahead. Catherine, sorry.
I will second that recommendation, Elise. I think that that's a good compromise. I would also like to see us put a link to the SURG report in there so that the individuals that read our report can look at it comprehensively, both the discussions that we make, the recommendations and the intentionality of the funding, and just how complicated it is to be Nevada and be dealing with this. So I will second that, Elise.
Thank you, Catherine. Before we go any further, I want to say that, listen, this discussion has been awesome. It has pointed out some things that do not sit well with us. It has pointed out some things that are confusing to us with the big gaps in the funding. It has pointed out some things that we would like some information on, but it has also highlighted over and over again that we have done some work to push forward recommendations that have had impact on the community. And I guess what I'm hearing is that we would like it to be as sharp as possible, as pointed and directed as possible from this committee to the community. If that is the case, then I ask that you write down some questions, that we do some work in between meetings, that we do some work in between biannual reports that are due. A lot of the time as the year goes by, I feel a sense that people really aren't that involved. We only hear from a couple people. Things don't seem to be, how do I say it, like on the heart, like super important to individuals that are subject matter experts to this committee member, and then bringing them forward and having a discussion with the committee about it. So now that we're at this point where we have a motion, we're going to take a vote. My request is these things that matter, these flaws that you see in the process, these questions that you have about the way things are done, let's dig into them and wrestle with them over the next year. Instead of having people come and present to us about things that we do or do not know about, let's take time to make meaningful scheduled meetings where we wrestle these ideas, where we go through these processes and get them clarified and lined up. That being said, we'll now be voting on the motion at hand, which, Elise, can you repeat it one more time for us, please?
Yeah, so the motion is to roll over the recommendations from the last annual report into this annual report. So the state will work under those recommendations, goals and objectives for the next 2 years, and we will incorporate the ranking of the SURG recommendations into the report, along with the conversation that we had today, as well as a link to the SURG report, so the record is complete.
All in favor, please unmute and give us an aye.
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 Quinny, was that an aye or not an aye?
Yes, it was an aye. My thing is a late response for some reason.
Thank you, Quinny. Now, any opposed with a nay, please unmute yourself and let us know.
This is Farzad. I'm not exactly sure. So are we saying that we're completing agenda item 4 as well, which is review, prioritize, and approve ACRN funding recommendations for inclusion?
Dang it, that might be my bad. I maybe should have rolled us out of here. Or I guess, yes, that's a good call. So I don't know how to do it exactly, but I guess what I would do is say, we're not closing agenda item number 4, but we are opening agenda item number 5. Smashing them together, if that's Apple, Henna, or Joan, is that possible? Or do we need to
That's
vote
fine.
twice? Because they
Yeah, you can
deal with both
combine.
issues. Okay, thank you.
You can
So
combine.
yes,
Yeah.
then Dr. Camiar, we're combining 4 and 5 into one agenda item where we are now taking a vote on the
whole shebang.
The whole shebang.
Okay, so
motion at hand.
So this is Farzad. Question. So if I have, you know how I mentioned that there's goals that are, and we're talking about the goals that are now further distilled down into those. Here's goal 4, which is treatment, and I've sort of I see one goal that I feel is really important that is not included. I thought at some point we were going to talk about those kinds of things.
Yeah, absolutely.
But now we're saying we're just going to roll everything over.
So right now we're saying that what we currently listed as recommendations, we're rolling the whole thing back over to pinpoint and highlight the ones that have not been, what are they called, funded.
Funded. But what about ones that aren't even on those lists?
Let's talk about them after this motion.
Got it. Okay.
No, I don't think we can do that because the motion, so that can't be the order. So the motion would be to just keep it as it is, Dr. Camiar. It sounds like you want to include other things, right?
Yeah, this is Farzad, and I will admit that I have not gone through each of these because I thought that there was only the ones that were identified through goal 4. Chair, like you had mentioned, I didn't see 1, 2, I mean, any of the other goals on there. I thought they were just sort of, we were going to get to those. Are we saying that the only ones that we're going to include are the ones that are in goal 4?
No.
No, it would be all of the so do you remember, Dr. Camiar, over the last 2 meetings, we've been looking at all the goals and objectives and with all of like the multicolored.
Right. Okay.
Yeah.
Okay.
So
Yeah. Okay. So then, yeah. So
all of those things.
So then I would say, unfortunately, and that's fine. I might be in the minority here. I unfortunately have not gone through each of those with a fine-tooth comb, comparing them to the previous statewide needs assessment where we had then said, here is our list of 100 and whatever recommendations, and done a one-to-one to see, oh my gosh, did we capture all these? The one I specifically noticed is it's under the treatment category. It's called Increase Education, Adoption, and Support for Buprenorphine as a First-Line Treatment for Reproductive, Birthing, Pregnant, etc. patients with OUD. There's some scores assigned with it. I've called out that I don't agree with the scores. Something like the legislative target on this one got a 0 when it's like I would argue it might be the goal that hits on the single most number of legislative targets. And if that, and then I have an issue with the impact score, it's a lower one. Regardless, if you throw in a legislative score of 3, because it's either 0 or 3 on this one, this becomes the second highest score of all of our recommendations, and it's left off of our list. This is, to me, unacceptable. That's unacceptable. And so now we're motioning to not add this to the list. Again, I haven't gone through with a fine-tooth comb to see which have and haven't. I didn't realize that that was an exercise I needed to partake in, so apologies. Yeah. But at least that's the one that I've identified in this, right, that I would want to add. But I don't know of all the others.
And it
So what's wrong
sounds
with hold on a second, Elise. What's wrong with rolling this over, continuing this motion and voting on it and then getting complete and then moving forward? But what's wrong with you know, then if the motion were to pass, then to have a conversation to include anything that, you know, to go back over. Hey, now we're going to have a discussion about anything that we're not rolling over that wasn't included.
Because that's where
not
we
something
got
that can happen.
sideways with the surge recommendations, right? So that's why I feel like we're in between a rock and a hard place, is if we're opening it up to include recommendations outside of what we currently have, then we also have to talk about including the surge recommendations, which there's consternation on. And I hear you, Dr. Kamiar, and it sounds like the problem or the heartburn is not with this process, but the process from 2 years ago, where there was scoring done by Mercer or whoever it was that was not transparent, that was not shared to us, and now we have been shoehorned in to recommendations that we don't agree with, and now we can't change.
This is Parzad. It's not necessarily that I don't agree with them, but they were scored in a certain way. And even that is fine. Like, okay, fine, take the scoring out of it. I just thought that all of those recommendations would have made it over to the 1, 2, 3, 4, 5, 6, and 7, and they haven't, clearly. Right? I'm just outlining one recommendation that is on our list.
Wait,
but
I got
not.
it. I got it. So I think the way that we can do this, because my understanding is the way that we got through this list of 7 goals is through the statewide plan, right? Which we helped through conversation and feedback and our recommendations craft a little bit, right? Like we guided that statewide plan. In the same way, we roll over what we have, and then afterwards we have this discussion about what we would like to see in the next statewide plan, which then covers those gaps that you're talking about right now, Dr. Kamiar, in the conversation that is to be like directly interpreted by the state staff that is going to finalize the statewide plan. We will say these things are missing, which is 1, prevention versus treatment dollars, the gap there, and how do we address that, which is 2, that the thing that you brought up about neonatal something treatment and how that's important and how the state plan ought to include that. As we have this conversation after we complete this motion, then the state staff will then be guided by our discussion to adjust and address these issues in the state plan. Does that sound feasible? I think that's the way. I think that's totally something that can be done and will, and like, I think it'll be done. Am I completely out in left field?
I don't know if I mean, does that work for the state's process?
I feel like that's what we got from Vanessa and what we've gotten from Dawn, is that in some type of way, our conversations, I believe so much so that that's how we got these goals listed out with the missing gaps that Dr. Kamiar is pointing out, is that like the highlight of the conversations focused around these. Vanessa, Dawn, Joan, can you jump in here to give us 2 cents? All right, how about this? Oh no, we can't. I was gonna say, let's finish our motion, but we shouldn't until we have an understanding of where it is we're going. So no,
Sorry.
oh, we got Vanessa. I heard it. No.
Yes. So I'm not 100% positive. Do you think you can repeat the question for me if that's possible?
So
I'm
right
sorry
now,
about that. I know there was like a lot of
that's okay.
different things.
So
being
right now
thought
we're
at
kind of
once.
stuck. We're kind of stuck between a rock and a hard place. We have a motion on the floor to roll over the recommendations that we've gone over and that have been implemented, and hopefully to keep the ball rolling. We're also stuck at a place where we're not sure how to move forward from what seems like a kind of a place that we're stuck at from 2 years ago. And so what I'm hoping is that the state can confirm or deny that once we move forward with our motion, the discussion that the committee has about some things that are not included on the recommendation and the report to the director's office will still be taken into consideration by our discussion through the state staff as they develop the state needs assessment plan, the state plan. Now I'm losing all my words.
This is Dawn. Sorry, David. So you want us to take into consideration everything that you're not putting in your report to the director's office?
My question
All of
is
our
this.
conversations?
Yes, my question is this. Have we had any effect on the state plan before?
Yes,
Like besides
we
the
took all of the
recommendations?
recommendations that you put into your report and we created activities. That's why you'll see that the activities are actually have a ranked number next to them.
Did we have any effect on that state plan regardless, without considering our recommendations?
Yes, because we consulted with you throughout the entire needs assessment and the state plan. So I guess
Exactly.
I'm
So-
confused as to the question. You're our
So the
advisory committee. We take everything you say into advisement and we use what you are saying in these meetings in order to drive influence in all of our activities.
Perfect. Committee, that being said from Dawn, does it sound feasible that we continue this motion, vote on it, get it done, and then advise and guide the state plan by having this next conversation? So I'm going to use one, our recommendations will go into the state plan as something that's going to be pushed through and funded. Two, we'll give them a sense of where we're at as a committee and as subject matter experts by discussing what is important to us in moving forward. Does that make sense? Did we kind of get closer, Dr. Camera?
Farzad here. Sorry. So what are we going to do about the discrepancy? What was the plan for the discrepancy? And I'll just give you, I try to just do a real quick count. If you look at section 6, which is our recommendations of the state plan, under treatment alone, which is goal 4, there are 81 recommendations. If you look at section 7, which is sort of the presentations that we've gone through with the color-coded items, treatment alone has 57. So let's say 25 are not there. Another one I just identified is promote, eat, sleep, console. And I'll tell you, this is probably number 2 on how to prevent neonatal abstinence syndrome in our state. Number 2. I'm going to go with number 1 is treatment with buprenorphine, and number 2 is eat, sleep, console. Both of those are not under 4. And I didn't go through 1, 2, 3, 5, 6, and 7 because I was quickly just doing this for 4. So 81 got distilled down to 57. I've identified 2, again, to me, that are massive towards huge priorities for the ACRN. These are specifically common. I'm telling you that we're specifically tasked with reducing NAS, neonatal abstinence syndrome. It's one of our sort of guiding principles. And promoting eat, sleep, console is not on there. And that is the best evidence-based method that we have to prevent it or to minimize it, like in the hospital at the time of delivery. That would be a huge miss. I mean, so I wasn't sure what we said we would do about the ones that we have and are going to roll forward versus the ones that we're missing.
Dr. Kamiar, we have 37 minutes of the meeting before the report is due. So I'm not saying that it can't be done, but what I'm saying is this is a priority. It sounds like it's super important. It sounds like something we're tasked with. I know you've brought up these important things before, and what I was hoping for today would be a list of things that you have gone through and then listed as, here you go, these are the things that I would like to see added in our report, and then we would do that. Right now, where we're at in this limited time, I say we push through the motion, or if the committee doesn't want to, that's fine, don't do that. But then after we do that, you bring that forward right there. So one thing that Dr. Kamiar feels that the state needs to consider in their statewide plan is the utmost importance of promote eat, sleep, console for mother baby dyads for testing with or for treating withdrawal. And now that you have said that, the state can use that information to guide their plan. So sure, it is not listed as one of our recommendations, but more importantly, it has been brought up to the forefront to help them create what it is they're going to do. So in the limited time that we have left, I want to hear those things that are important to you that we are not directly rolling over. Yes, Dr. Kamiar and committee, not just to point you out, Dr. Kamiar, myself included. We presented this giant list and it got diluted down and then diluted down, and now we're at where we're at. Let's move forward with what we have. If you see anything on this gigantic list or anything that comes to mind today that isn't on this list, after we push through this motion, we bring it up in conversation to help guide the state with their plan. Does that sound like something that could be done?
Yeah, no, totally. This is part of totally. So I'm gonna totally take that as my shortcoming, as I did not go through to come to this meeting with that list. That is the difference. I sort of remember like one of the action items from last visit was going to be to visit the scoring rubric because I had asked for that to happen, to go through items and say like, hey, I don't agree with this. I didn't realize that I was supposed to come to this meeting with the delta.
Right.
Yeah.
Right.
Okay, then I'll just go back on mute and we can continue with that motion.
Copy that. Thank you, Dr. Kamiar. And listen, I don't want you, I hope you don't take it as the mess that I am in trying to guide this mess, that I'm attacking you or putting anything negative towards you. I really appreciate the deep conversation. And honestly, with or without a direct, hey, state, we're saying this so you can help come up with your plan, they're listening to us and taking this into account towards their plan. That's for sure. That's the way it had been done in the beginning, and that's the way it's being done right now. Moving forward, I'm going to reset us back to the beginning of Elise's motion, which is still on the table, and we're going to start from all in favor. All in favor of the motion to roll over our current recommendations and include our ranked list of SURG recommendations with the the whole of this conversation and how it needs to be addressed, but summarized and reformatted in a way that makes sense, to our report to the director's office. Please unmute yourself and give an aye if you're in favor.
Aye.
Aye.
Right.
Aye.
Aye.
Oh, and one there was a robot one there. Was that, it was either Malika or Quinny, I'm not sure. All right, I'm counting it at 7 right now. Anybody else that I missed or didn't hear? I heard pretty much everyone except for those last two. All opposed to the motion, please say nay. Unmute yourself and say nay. I'm hearing none in opposition. Any abstention? Please mute yourself and get abstention. I counted it as 8 fours and no against and no abstention. Can I get a confirmation from state that we're good to go on approving this motion and moving forward? Hannah, do you see any problems with it?
I
No,
think
there
you're
was audio problems. Okay, thank you. All right, the motion has passed. Thank you, Elise. Thank you, committee members. In the grouping of agenda items number 4 and 5, before I move to public comment, which I know I have to move there before 15 till or something. Does that sound right, Joan? Whenever I have to move to that, now is the time. Being that we have a bunch of our recommendations that kind of fell off or got diluted down into not being a part of what we currently have. We've heard Dr. Kamiar acknowledge that one important thing to him that the state considers is the promote, eat, sleep, console for mother baby dyads for treating withdrawal, which is directly tied to reduced neonatal abstinence syndrome. It hasn't been rated and it's a part of treatment, but that's something that Dr. Kamiar, and thank goodness he did, has brought up that I would love the state to consider as they create their plan. It seems like we're missing a section of treatment that could use a ton of support. Anything else that folks are noticing or that folks would like to bring up now from the committee that they would want to see the state consider, talk about, bring forward, that isn't going to be directly, may or may not be directly tied to one of our recommendations, but that needs to be on the board. We've heard the discussion about treatment over prevention, the importance of prevention and not leaving them out, the topic about supporting more prevention, and we've heard in previous meetings the disproportionate sense of funding for harm reduction. Does anybody want to speak to any of those? I will repeat a sentiment before I call Elise. Is one thing that I'd like the state to consider or discuss or bring forward in their plan is the mismatch of funding for harm reduction, which it was pointed out that it was like 140,000 per year, and that something like 5 to 10 times that amount being tied to some type of programming that are linked to our recommendations would be excellent to see in the future. I have good feelings about this, and I believe that they're already on top of it. If that is the case, please give us the information that lets us know what that looks like in action. And if that is not the case, then I would advocate for that to be highly considered as a need and urgency of this committee, at least this committee member, and I believe this committee. Elise.
Thank you, Chair. So yes, I would also advocate for an increase of harm reduction dollars. We heard a really great presentation a couple meetings ago about wastewater testing. I think it would be great to ensure that we are funding response teams that can do something with the outcomes of wastewater testing. I'll say I don't support funding that vendor. I think it was too expensive, but we know the university and the local health districts are already doing wastewater testing, but ensuring there are response teams that can respond would be great. I also think it's important to Jamie's points on the call today to understand kind of where the prevention funding is going. If we have prevention dollars that come into the state that are going towards treatment, I think the state should look at ensuring that, we're seeing more than 20% of those prevention dollars going to prevention.
Awesome. Awesome. Thank you, Elise. Again, this time is the time that we're going to speak on the important areas of supporting the remediation of harm from the opioid epidemic that may or may not be included in our recommendations, to put them on the radar of the state staff who will be creating the yearly plan. Sorry. Anybody else have anything to say that they would like to make sure that the state is looking at Okay. Okay. Before we move to the next agenda item, which is going to be agenda item number 6 for public comment number 2, I would say that when we get the draft minutes for approval, which will be listed on our website, it gives a recap of the discussions that we've had today that are important to folks on this committee, that are important to guiding this committee in the duty that it is meant to do. They really take the time to be involved. As we move forward, things generally slow down after we make this report, but I say we stick with it. I say we stick with it because there's some issues that seem to be pretty loud and pretty inconvenient to getting our jobs done, to getting our roles complete to serve the community. If that's the case, there's a lot of discussion to be had in both clarification and guiding the processes that make this thing happen. If it's not working well and it's a problem for the committee, then let's do the work to get it done the way that would serve the committee best, or the community best, at least to make little gains at a time. So again, normally we would be slower on meetings, but I'm going to be pushing meetings out monthly. If this is something that you can't attend, then maybe we consider having subcommittee meetings to bring back to the committee as a whole. Either way, I'm asking for more feedback. I'm asking for more participation. I'm asking for more of your time. If that is the most you can give is an email to me and the state staff, then please email and give your thoughts. I'm looking for help on how to guide this committee in a way that it feels like we're doing something that aligns with our goals and our what we've been tasked with. It seems like there's a sense that we're not meeting that. And even if that's the case, we are making recommendations. We are guiding funding through these conversations that are positively impacting the community. Where there are gaps that hurt your soul, that make you feel like we're missing the mark, speak to it. Come to the committee meeting that we're going to have next month and talk with the committee about it. If that's something you're not comfortable with, write me an email so I can bring it forward to the committee as a whole. This sense of things are going wildly off target, I don't think that I'm alone, or Dr. Camero, or that I recognize that the committee recognizes it, and now I want to do something about it. So with that, I will need your help. Thank you for the work that we've got done so far. And also, the community is being positively impacted by this. If we want to fine tune it and hone it in a little bit better, let's do that. I'm going to close agenda item number 5 and 4 that I combined. I'm going to move us forward to agenda item number 6, which is public comment number 2. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment, telephonically dial 775-321-6111. When prompted to provide the meeting ID, enter 500-416-849#. Please note that if you're joining by phone, press 6 to unmute yourself, and press 5 to raise your hand. In consideration of others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. No action may be taken on a matter discussed under this item until the matter is included on an agenda as an item on which action may be taken. We have anybody available or interested in providing public comment as part of public comment number 2? Joan, do you see anybody? I'm not seeing anyone currently.
I do not see any raised hands or anybody unmuted.
All right, we'll give it a couple more seconds so we don't leave anybody out. I know that this virtual meeting space can come with some technical difficulties, and I appreciate you guys being patient with us. All right, final call for public comment number 2. I currently see no hands up for anyone interested in providing public comment number 2. Going to move us to agenda item number 7, which is the adjournment of this meeting. Our information will be posted on our website. I'd like to thank the committee members for taking the time to be here and to speak to us about the issues that we go over. And I also would just ask that you bear with us as we take forward to continue supporting the community. It's not perfect and it's not easy. It is complicated and it is messy. So thank you for taking the time to be here today. This meeting is now adjourned.
Aye, thanks.
Thank you.
Bye.